So, what are teeth actually made out of? I'm Dr. Amelia and I'm gonna break that down for you. Because if you want to do good cosmetic dentistry, or any dentistry for that matter, you've got to understand the fundamentals. There's a lot of literature out there about it. I'm gonna make sense of it. What do I actually use on a day-to-day basis? And what's actually relevant so you can deliver awesome, predictable results for your patients. Teeth are like onions. They have layers and they're made up of pulp, dentine, cementum, and enamel. Let's start from the outside. Enamel's that white outer shell that you see as the tooth's crown. It's a dry structure that doesn't contain anything vital. I often explain to patients it's like your fingernails. You can cut them, but you won't feel the process of cutting it. Its composition is 96% inorganic, also known as hydroxyapatite. It's a real buzzword in the dental product space. And 4% organic/water. It has crystals, and the crystals are comprised of a mineral called calcium phosphate. These are arranged in a crystal structure, which is the hydroxyapatite. They're also known as the enamel rods. These rods are a highly organized system, and they have this keyhole, almost fish-like shape. The prisms themselves have a core and a sheath around them. Inside that core are the tightly packed hydroxyapatite crystals. The sheath has less crystals, and it has more space for the organic component. Now we're gonna get real technical, but it is actually very important. In different areas of the tooth's crown, the enamel rods are orientated slightly differently, and that can impact your bonding. For example, the enamel rod's long axis is typically perpendicular to the CEJ. And for those of you who don't know what perpendicular is, because I always get confused by it, this is what that looks like. This is the case in both permanent and baby teeth. And the reason why these enamel prisms/rods, whatever you want to call it, follow this path is because of the existence of ameloblasts. Those are the little guys who deposit enamel during the developmental process. The way I remember it is, it kind of sounds like my name. Something to note, in permanent adult teeth, the enamel prisms tilt slightly more apically towards the root of the tooth, which can make bonding in that area a little bit less predictable. Knowing the orientation of enamel is very important in dentistry, because if it's unsupported by underlying dentine, it can be prone to fracture, and we don't like when things break. The good thing about enamel's structure is that it is dry, and this makes it the ideal substrate for bonding because it forms a really good tight seal when you use adhesives. This was discovered by one of the dental gods, a guy called Bunicor, back in the 1950s. It was based on an industrial technique to adhere paint to metal. That's actually an interesting thing. I studied panel beating, and a lot of the products that we use in dentistry are made by the same companies. But in order for us to attach stuff to enamel, we actually have to change the structure. And that's where the discovery of etching enamel is very beneficial. This process involves etching the surface with phosphoric acid, normally around the 37 to 40% mark, for 15 to 30 seconds, depending on the generation of bonding that you're using. And that is something that we are going to discuss in the future, because that is a whole nother deep dive. And why do we etch the surface? To clean the surface from debris and to increase the surface area of the enamel. And this is done by dissolving the hydroxyapatite crystals, which creates these micro-retentive porosities, which allows for what we love, micromechanical retention through the formation of resin tags, which allows you to lock into the enamel. The other material you find on the outside of the tooth is cementum. This is a connective tissue that forms along the outside of the root of the tooth, and it helps to solidify the connection between the periodontal ligaments, which are fibers that hold the tooth into the bone socket and keeps them in your jawbone. It's softer than enamel, and the PDL fibers are embedded within it. Cementum also has the function of covering its dentine. It doesn't have nerve innervation and feeling like enamel. However, unlike enamel, it's challenging to bond to. And then we come to dentine. This is the middle part of the tooth. It's a whole nother ballpark, and it's not always been the most predictable thing to bond to. The latest literature says that it's composed of 70% inorganic mineral, 20% organic matrix, and 10% water. And dentine has tubes. A lot of the time, when you get sensitivity, it's because those tubes are exposed in some way. Dentine's sort of broken down into two parts. So you have tubular dentine and intratubular dentine. I know, it's pretty exciting stuff. The tubular dentine is lined with highly mineralized peritubular dentine, made of mainly hydroxyapatite, and within these tubes there's fluid. I feel like I should have started a drinking game where every time I say hydroxyapatite, you have to take a shot. You guys would be wasted by this point. The intratubular dentine contains collagen fibrils. The thing about dentine that makes it tricky is that it's quite a wet structure. The fluid flows outwards, which can impact the ability to adhere to it. And the density of the tubes and the concentration of water varies depending on how deep you go within the tooth, which you don't really have control of if there's decay and disease that you need to clear out. The deeper you go, the more water concentration there is, and therefore there's a lower bonding strength. And to add to the fun of dentine, there's also a smear layer. When you prep a tooth, it forms a layer of debris. The debris is made up of crushed hydroxyapatite, drink, and denatured collagen. This smear layer obstructs those tubules, and it can create a plug that's up to 1 to 10 microns in thickness. It's a commonly held thought that that can actually reduce the bond strength by up to 87%. So how do we get rid of it? You've got a couple of options here. And again, this is why it's so important to understand the generation and the technique that you're using when it comes to your favorite bonding systems. So do you remove it or do you work with what's there? You have the option to either remove it, which involves etching or conditioning the surface. If you choose to etch it, this will dissolve the mineralized part, which is the hydroxyapatite, and it will leave the collagen network suspended in the water. The water is important because it stops the collagen network from collapsing. Post-etching, the surface is dried, but you have to be careful not to over-dry it because it will remove too much of the water from the surface and the collagen fibrils will collapse, which ultimately means that there's not as much structure for the bonding agent to diffuse into. But if it's too wet, it will reduce the bond strength anyways because the water will dilute the adhesive. So really, it's very technique sensitive. And this is where your choice of bonding system is so important. Using something like a hydrophilic will help to infiltrate that moist collagen network. When the adhesive infiltrates the dentine surface, it forms something called a hybrid layer, which is neither tooth nor resin. And this hybrid layer has a few functions. Number one, it prevents entry of microorganisms and toxins to the pulp. Two, it reduces the incidence of secondary caries because we don't really want decay under the filling that we've just placed. Three is it reduces micro leakage. And four, it reduces post-op sensitivity, which will make you very, very popular with your patients. The other option we have with the smear layer is to modify it. This is where bonding systems that have a self-etching component come into use. The smear layer isn't removed. It forms part of the hybrid layer. And then we have the center of the tooth. The pulp is not my favorite thing because it's the thing that causes all the dramas a lot of the time. It's the innermost layer of the tooth, which is a bundle of nerve fibers and blood vessels. It's a living, breathing, sensory part of the tooth. It resides within the tooth directly beneath the dentine layer, often referred to as the dentine pulpal complex, also known as the endodontium. They're very closely interrelated and are ultimately dependent on each other for their survival. So let's get into the fun stuff. What can we bond onto it?